All right, good afternoon, everyone. On behalf of the Wisconsin Cancer Collaborative, I want to welcome you all to our virtual 2021 Wisconsin Cancer Summit. My name is Beth Brunner, and I'm the Program Director for the Wisconsin Cancer Collaborative. As the Program Director, I have the privilege to work with many cancer control leaders throughout the state, including our Wisconsin Cancer Collaborative. Before we get started today, I just wanted to, again, thank everybody for coming. I'm excited to see all of you today, although virtually, just new names, familiar faces, and I'm really excited that we can continue to connect and learn in kind of this new modern way, right? Our virtual space. We hope it won't happen, but if there seems to be some unforeseen issue that pops up, we do have a staff team standing by and all of our presenters in different locations during the summit. So just know that stay tuned, stay with us. If something does come up, we're going to work to resolve it really quickly and continue on with the agenda. I also just like to give people in this kind of virtual space how we can connect virtually is a way of just putting our names and our organizations. So on the screen here, you can see that there are ways that you can rename yourself, put your organization in your name, and just let us know where you are and where you're joining us from. I do want to just take a few minutes that the Wisconsin Cancer Collaborative acknowledges that we live and work on the unceded homelands of Indigenous communities, and that we recognize that us as our program staff located in Madison occupies the sacred ancestral lands of the Ho-Chunk people. We respect the inherent sovereignty of the Ho-Chunk Nation and all 12 First Nations currently residing in Wisconsin. So we make this acknowledgement to honor the history, culture, traditions, and rich legacy of the Native peoples who have lived here, and we honor all Indigenous peoples with the traditional land ties to this land and vibrant Indigenous communities here today. So as healthcare professionals, we recognize our responsibility to help reverse the history that has created our present day health inequities. And we encourage you to join our commitment to partnering with Indigenous communities in ways that are grounded in respect, integrity, and reconciliation. So I also, as part of this, want to say that part of this amazing team is our steering committee. These are our volunteer leaders that help us guide our work, they are dedicated, passionate, and supportive colleagues of ours. And we just can't thank you enough for all the time and effort that you contribute to making the Wisconsin Cancer Collaborative what it is. So thanks you to all of you. And now it is my pleasure to introduce you to our steering committee chair and MC for the day, Dr. Melinda Stolle. Dr. Stolle is a professor and associate director of cancer prevention and control at the Medical College of Wisconsin's Cancer Center. She is a health psychologist, and her research focuses on health behaviors and health behavior change that can improve patient-reported and cancer outcomes. With nearly 20 years of experience developing and testing lifestyle change interventions, with children, adults, and cancer survivors, an important aspect of her work is her focus on communities of color and underserved communities, working closely with community organizations to answer relevant cancer questions. As I mentioned, she is currently the chair of our Wisconsin Cancer Collaborative Steering Committee and has been a member since 2017. I cannot thank her enough for her tremendous guidance and leadership that she provides to all of us and the help that she gives to our team. So please welcome Dr. Melinda Stolle.
Thank you, Beth, for that kind introduction. And I'm so honored to serve in my role as chair of the steering committee, and just encourage anyone who's not part of the collaborative. It's an amazing, amazing resource network of organizations and individuals, and I've really gained so much from my participation in this team. So we're here virtually. I think we all did not want to be. It's a beautiful fall weather, and we'd be so happy to be in the Dells, I think, instead. But when the WCC team decided to move forward with an all virtual summit, it was important to note that we did this, or Yeah, because cancer continues to impact our communities, as we certainly were so critically aware of over the last couple of years. And more than ever now, we need to come together, we need to collaborate, we need to communicate, and we need to serve in the best ways possible. So as we move through this day, I know it's hard to keep connected to Zoom, and we always want to be doing things in the background, but I urge you to think about our goal, which is to provide an opportunity for us to come together and network. So we'll be doing breakout groups, question and answer periods, to learn from our partners throughout the state and think about the perspectives that other people hold. We have our own, but it benefits greatly from when we think about how other people think and experience their lives. Listen and explore ideas on how to continue to move our work forward during the pandemic, which just seems to go on and on and on. And then also to think about and understand how community health impacts cancer outcomes. So kind of get out of our tunnel vision of cancer and be thinking more broadly about community health. Now, before I introduce our next speaker, I started this call today saying, wow, look at Team Summit, this amazing Wisconsin collaborative team that pivoted to a virtual. They are working in the background constantly to address the cancer burden in our state. And I really want to recognize the amazing staff at the Wisconsin Cancer Collaborative. They do a remarkable job every year and actually every day. This team is a resource. And so see them as a resource. There are amazing things on the website and the expertise that each of them has. So if you have questions, reach out to them. And between the summits, reach out to them as well. So Beth, Dr. LaConte, Allison, Amy, Carrie, Tina, Alex, Alexandria, Mary, and John, thank you. Okay. We have an exciting agenda for you today and tomorrow. So our first day of the summit goes until 4 o'clock today. You're allowed to get up and take little breaks. We hope everyone signed up tomorrow. You do need to register separately, so don't forget about that. We start at 8:30 tomorrow, and you can still be drinking your coffee and in your PJs, which you couldn't do if we were in person. And our full agenda is available for everybody on the website. Okay, so if you have questions today, what we want you to do is enter them into the chat box, okay? And then somebody will be facilitating that in the background and asking your question. And if you need technical assistance, there is someone in the background ready to help you. So reach out. You can also reach out in the chat there too. Oh, and look, Alexandria put in the chat the registration link for tomorrow to make it easy for everybody. Okay. So I'm really excited about this one because I've been wanting to hear this guy talk since I heard about him from my friend and colleague, Lola Awayinka. So I am pleased to introduce our first speaker of the day. Joshua Wright is a community project coordinator with the Cancer Health Disparities Initiative through the University of Wisconsin Carbone Cancer Center. He plays a critical role of engaging with organizations, groups, and individuals that are doing work in their communities through health awareness initiatives. But I'm sure he does much more than that by helping address the mistrust and the just sort of breaches that go on unwittingly oftentimes between institutions and communities. As a community project coordinator, Joshua works on supporting understanding and participating in ongoing efforts throughout the community that provide effective components to improve the health outcomes. And we are looking forward to hearing about your work, Joshua. Thank you.
Well, thank you, and good afternoon, everybody. I was just so pleased to be able to have this invitation extended to talk about community outreach and engagement. Just want to start off by giving an extra thank you to the coordinators and the organizers that have been mentioned prior to, just wonderful work everybody's doing. And I'm going to take today's opportunity to talk about community outreach and engagement, and expecting to highlight the connection points um, of how I've seen positive outcomes through this work. And so thank you, Dr. Stolle, for just mentioning that this work does expand beyond just the descriptive points. And I'm hoping to get into that. And just wanted to say that I chose the title of the presentation for today, the On the Journey Together part, just as a key reminder that, the work that we're doing to win battles against cancer is a collective effort. It always has been. And, we see that there's this intersection between survivors and medical professionals that provide care and treatment. And this is immensely fortified by the ways that we are connected and intertwined with communities, and how they're included in the aims and goals of cancer centers. Next slide, please. So just wanting to start out with a couple of definitions, and we see here a couple definitions that come from, one is on the left, is from the Center for Disease Control. They have an Agency for Toxic Substances and Disease Registry, and they partly define COE as a recognition of why people come together. So, being able to say, this affiliated geographic proximity and special interest, these are the things that are the why people are engaged in the work collectively. And also looking about understanding how those folks are going to be instrumental in being able to open up ways and resolving obstacles to this path of improved well-being. On the right side, I took this snippet from the World Health Organization, and they are mentioning that, or acknowledging groups that are impacted by the negative circumstances are, again, essential and instrumental in correcting and directing the activities that will be best suited for their population. And so, we have here just the kind of national or international understanding of community outreach and engagement. Again, just kind of those working pieces that really apply to the things that we're going to talk about. Next slide, please. So now we have the interest or the specific reasoning coming together. We have the layering effect of community outreach engagement through the National Cancer Institute. And so we're seeing that, the why of the work is to eliminate the impact of cancer. And we're seeing the what and when here, and how the engagement is happening. So, we have this also nuance happening, or this dynamic between internal, inside cancer centers, and the external. And so we want to engage with leadership and make sure that the research or the programming within these cancer centers is something that is understood. There's the assessments that are happening. We need to come to the community, identify those things. And so there's lots of processes happening around, doing those needs assessment, updating the needs assessments and stuff like that. So, this is an ongoing circumstance that we find ourselves in. And, we also are looking at the expectation of the level of rigor when implementing these objectives in communities or with communities. And so we talk about evidence-based. We want to have research and data that backs up the effectiveness of what it is that's going to be used from this direction from the Cancer Center, the National Cancer Institute. And yeah, so, just thinking about these things, we understand that this is, again, attached to funding and things of those sorts. So they are important ways that we need to be able to frame and understand how to talk about the work. And so, those are the reasons that I like to kind of come from the big and work our way down in these definitions. Next slide, please. So now we get to the Carbone Cancer Center. And so the mission of reducing cancer burden and health disparities. These things are specifically being acknowledged because of what we talked about in terms of kind of similar to the land acknowledgement, right? There is a historical foundation and current power distribution that necessitates us being able to add on these extra understandings to the work and how it's being done, right? We also think about what it is that the Carbone Cancer Center is doing in terms of coupling the work together. So we have the population sciences together with community outreach and engagement. And this makes a lot of sense to me because it's about saying, hey, you know, cancer is impacting groups differently. And so how is it that we are wanting to do this work collaboratively, and these two entities coming together to look at the circumstances makes a lot of sense to me in terms of saying, hey, we have epidemiologists and we have, you know, people that are understanding the trends within populations, and then we're going to from there be able to make some kind of sense of what it is that we need to do to come to terms and address these issues. Next slide, please. So now we have this smaller unit within the population sciences division here at the UW Carbone Cancer Center, which I work in, which is the Cancer Health Disparities Initiative. And we have the prioritization of, you know, working in this framing of health disparities. And we are saying that we are committed to working with communities, but also we're doing that acknowledgement that the NCI talked about in terms of in reach. So we're looking to researchers, we're looking to clinicians across Wisconsin and beyond to improve the health of everyone that faces a greater cancer risk. You know, we are using these understandings and trying to express clearly the who, the what, and the how. And so this focus on disparities, again, is something that we find through the data. You know, it's not something that we're just hearing anecdotally, even though there are lots of stories out there that you can look at and pull up to say, man, there's something here. But, you know, the data is driving, and we understand that certain groups are experiencing higher incidence and mortality rates when it comes to certain types of cancer. And we have the big responsibility of bringing awareness to those issues of cancer inequities. And so from here, I'd like to, you know, really dive into some of these examples of the partnerships that we have fostered over the years. Actually, if we are ready to move on, I'm ready to do the next slide.
Yes, I thank you so much, Joshua. Hopefully we are set to go, and let's see if we can get to the next slide for you. Are we all set now, Joshua?
Yes.
Okay, perfect.
Yes, excellent. Thank you. And so next, I'd like to, you know, bring up the Meadowwood Health Partnership, and they conduct and host events and provide connection and resources, and they promote education for underserved populations and families in this specific Meadowwood neighborhood. And so CHDI has been welcomed into this space and collaborate with them to do this awareness building around, you know, cancer within the African American community. And you know, they do a regular community supper, or they did a community supper that, you know, we have participated with and been there as an information table since 2016. And they also have conducted health fairs. But, you know, they also, you know, just keep our number handy when they want to talk more about cancer. And so in this specific opportunity, we have, as a unit, we have a curriculum called Cancer Clear and Simple, and it talks through cancer basics, prevention, and screening as 3 sections. And so we are always finding ways to bring that into community. And when we got this call was specifically to say, hey, let's, you know, we have breast and cervical cancer, or, you know, cancers that are specific to women. And we want to bring in more information. And I was able to come into this space and really just walk through some of these things about cancer basics. And what's really important or huge in this moment is I can't assume what people know. And when it comes to cancer, we know that a lot of people are impacted by cancer, but until it hits you, there's not a lot of reference points to the medical terms that come up when we're dealing with cancer. And so it feels really nice to have a curriculum that we developed in-house in the Cancer Health Disparities Initiative that uses health literacy principles, that is set at an 8th grade reading level, and really walks through these terms that come up. Metastasis, we talk about where cancer, primary cancer sites, being able to remind people that cancer will start in a specific area of the body, and the danger of it is that it's going to spread. And so when we bring these messages into spaces like this, there's usually a couple aha moments. You see the light bulb come on when we talk about these things, because it's in this particular instance, I remember that another presenter started talking about the BRCA genes, and they just launched into it, and I was like, well, I'm here to be able to talk and stepwise through it. We know that there's gene expressions that happen, but let's kind of start at a simpler way to be able to talk about this, so people, when they get to that conversation around genes and how hereditary incidents may happen, they're not confusing it with just the jargon that goes on that we may be more familiar with if we have closer proximity to cancer. And it also goes back to what I was just saying in terms of before I got into this work and before I started understanding what prostate cancer is, I had no clue. I really didn't have any kind of idea about these things. And so it feels really good to have a way to be able to talk people into a way where now they are prepared to ask better questions, more specific questions. Do I know my family history? What does that really mean when it comes to asking for certain types of cancer screenings? Because just with closer proximity to the medical field, we understand that sometimes misdiagnoses happen, or we don't get the right diagnosis because we've spent extra time looking for other things that it could be. When people have the advantage, they know, hey, my family has a history of X, Y, and Z, so I'm here to get this specific screening. Goes so much further in terms of being able to have better experiences. And that's, again, one of the kinds of things that we're looking at when we're talking about working with communities. We're wanting to help their experience with whatever they're dealing with medically go a lot better. Here also, with their too quick. The social determinants of health, really play an instrumental role in this, because we understand that, socially, people don't always come into this information the same way. And so I wanted to lift up the fact that, this particular example of the Mental with Health Partnership, they do a great job of doing that understanding with the social determinants of health. Now, next slide, please. Thank you. There was a series of men's health talks that I was able to engage with Second Baptist Church around. And, this congregation has existed for 60 plus years in the Madison community. And, with the leadership that's happening right now, they make an intentional effort to provide presentations, but also just, a way for people to come together to address health issues. And so when I was doing the work around prostate cancer, was able to get introduced and network and be brought into this space and be invited into this space. And so we were able to start with just having that basic conversation around prostate cancer and prostate cancer screening. But things went well enough where we were invited back, and it was also an understanding of, okay, well, there's other issues that men want to be able to have information around. So those connective prevention ways that cancer is overlapping with, we can talk about diabetes, we can talk about hypertension, we can talk about stroke, we can talk about heart disease. Those things that are prevention work for cancer are also prevention work for these other types of chronic illnesses that populations may be facing. And so it was this opportunity that really helped get me into presentation mode and be able to bring in other complementary experts to talk about these different things. And with what we're seeing now, this was before the pandemic, but men and mental wellness is something that doesn't get a lot of conversation time, right? And so we were able to do some exposure by bringing a mental wellness coach, Dr. Logan Edwards, who just does a great job in being able to talk about the differences between mental illness and mental wellness, and really give some solid tips around coping mechanisms or just strategies to be able to keep things maintained. And so we get to talk about these things all while being invited into these spaces. And it's similarly to the Meadowood Health partnership, talking about the holistic ways that we face health. We are a whole body going through an experience. And so sometimes we, get into these side conversations, but it's like an opportunity to say, oh, okay, so I'm picking up on what it is that you're saying that you want more information around. Next time, can you invite a friend and we'll talk about what it is that you mentioned here? And so in that type of way, this has been a very fruitful collaboration and just ongoing partnership with this particular church organization, and just being able to expand on the topics. And sometimes we can circle back to topics, but with this situation with men as well, we don't necessarily think of men as a whole group experiencing like disparities, but when I started looking at the numbers, it really is a situation. And then we can add racial and ethnic background into it, and you can see things get really out of I'm stunned when I see some of these numbers. So this specific example I'm alluding to is lung cancer, right? Lung cancer is something that impacts men a bit more, and I think it heavily is founded in the social and cultural thing around smoking, right? When I think about old advertisements and stuff like that, it's always this guy who's expressing his masculinity through being rugged and smoking. And so now we are here in this situation where, there's been a lot of pullback between, about advertising, and now we're in this situation of vaping. But I was, able to give a presentation around lung cancer in men, in Black men. And so, just to be able to say, hey, this is something that we need to continue to keep our eyes on and have awareness around, because it is an issue. And when it comes to this prevention work, it's so important about helping men be able to do early diagnosis, because we are talking about lives. In the report that I mentioned earlier, we have a graphic, and we're talking about how many lives could be saved if prevention was something that was being actualized within the African American population. And it was 40 lives out of 100 could be saved if we were able to do better with doing the early screening and the early detection. So that is what I would like to say about that slide specifically. So now we're getting closer to, what has been a recent phenomena of doing community outreach and engagement, right? So there's been a lot of things that have been pushed virtually, including this wonderful conference. But, this was an opportunity where organizations, when they went online, we were right there with them to be able to support. And so similarly to what I have been kind of talking about is saying, hey, we have an institution of medical professionals that we have closer access to, and we can feel more comfortable reaching out to find whomever it is that needs to be heard from when it comes to certain circumstances. And so with COVID, there was a lot of, information that was needed in June of 2020, right? And so we were able to bring in a virologist here. We were able to bring in an oncologist here. We even reached out to the community members and being able to give their real lived experiences of what was going on. And so, just in this opportunity, it's a representation or example of saying, hey, who is it that you want to hear from, and what powerful information do they have to share? And so while COVID was going on, and being able to be on the prevention side of things, the kind of cancer prevention side of things, it's like, hey, we're going to, because this is what you want to hear about. Yes, cancer is important, but this is what you want to hear about right now. And so we are going to bring you what it is that you are wanting to hear about. And Dr. Cheryl Henderson was kind enough to just be on a circuit, really. Like, I know I asked for her presentation in a couple different instances, but she was out there really just being a voice, of an expert voice, and just talking about what it is that was the current situation around COVID-19, and explaining, breaking down the term coronavirus disease. That's how you get to COVID. And so these things are things that were appreciated in terms of the community organizations that wanted to have people come and talk about these things. And so, with an organization, Kuji Chagulia Madison Center for Self-Determination, they've hosted an annual Juneteenth celebration in the Dane County in Madison for over 30 years. And so, they always are looking for ways to prioritize health in the community, and while doing the celebratory pieces around cultural and ethnic heritage. And so, we have been there in the in-person health fair dynamics, as a table, information table. But, when they took it virtual, we were able to just really step in because of also the technological capacity that we are able to have, right? And so, we are going to take on saying, hey, we'll set the Zoom, we'll set the registration up and everything like that. Just be able to, direct people to this space when we're on the program. And so, it goes just such a long way in terms of just saying, hey, we are bringing whatever it is that we have to the table so that the work can be quality, and you are getting the best information that there is to address what it is that you're wanting to address. And 2021 was also another virtual opportunity for this specific organization, as we were able to replicate the 2020 version of the virtual health aspect. And so with having a long-standing relationship as well, while being one table was great, and we were able to have a physical presence at this celebration, when it came to this virtual thing, it was like, okay, we've entrusted you enough in these type of small ways, and since you have the technical capacity, we're actually going to have you just really hold the health component of this whole programming that's happening over a couple days. And so that was a big responsibility that we were able to take on, but we were entrusted with that because of the ways that we were present before, and the relationship was on a solid foundation. Right. Next slide, please. This example I wanted to bring up because of, the ways that the community, has different needs, has different wants. And this also goes to that community-based participatory research style of engagement, right? So the community is saying, hey, we need this. We want a report that talks about what it is that's going on in our community, right? And we want to do it in a way where we're highlighting the assets. We don't want to come from that deficit perspective, right? Because with health disparities, are always the kind of starting point is, oh, this group is behind, or this group is experiencing something more acutely, and we have to come in and be able to lift this up or be able to close disparities. When in actuality, this example is being able to say, hey, these are the things that the community already does well. And so we want to talk about those things. And what we were able to do is go through an interview process through having the community partners and hear from them what areas they want to lift up. And from there, we are able to do some complementary. No need to add extra time. Thank you. I'm looking forward to getting some conversation going. But what we were doing is being able to bring the complementary information. So kind of to contextualize the narrative that they're putting forth. How many people of this group is in Wisconsin, or in these parts of Wisconsin that we're specifically talking about? And being able to really show that this is what they're saying is happening as assets and things that are valuable, things that we should know as supportive organizations. So they're not just dealing with us as a cancer center. They want this information to be able to take to potential grant funders and say, hey, this is something that we were able to pull together. It's a polished example. And so we worked with them as well along the way with a graphic designer. We were able to, hire a graphic designer, and we sent them copies as we're making tweaks and edits here and there. And we really walked through and got their approval each step of the way. And then most importantly, the dissemination. It's like, okay, so now we have this great document. Here you go. We're going to print off some copies, and we're going to, mail them to you for you to be able to give out as needed. And so voila, we have a wonderful community document that really just is something that was birthed out of what their needs were. And so it felt really good to be a part of this process of saying, hey, we are going to use our resources to highlight what it is that you want to highlight. And yes, we were able to talk about cervical cancer, HPV vaccination, but it's a smaller part towards the back of the document, because this is something that exists, but it's not, and that's something that I think we struggle with as well. We see cancer impacting so many on a high level, when in actuality, cancer is an age-related disease. There are, lots of exceptions that are happening for younger folks, and we have children's cancers and stuff like that. But if a community wants to lift up other aspects of what's going on in the community, who are we to say, hey, no, we want you to prioritize that this kind of cancer is an issue and you need to do something about it? No, this is something that we want to just give some exposure to, while being able to talk about the many good things that are going on in your community. All right, next slide. So, just wanting to wrap things up by saying, the definitions that are being used are going to set the direction of our work, and the activities range. There's as creative as you want to get there. That's how many opportunities and activities are going to be out there. But a lot of things that I find myself doing is spreading awareness, the education parts, and then I gave an example of a research project that was able to come about. But the research projects can be a little bit more difficult, and so we are willing to do what the community is ready and able to do. And so where does the community fit in the scope of community outreach and engagement? And we want them to be involved as much as possible, ideally at every phase. And so when we're talking about co-creation and planning, we have ideas of doing specific events and stuff like that, but it's always great to hear from the community what types of ideas they want to get going. And I know support groups are something that are really key in being able to work in this kind of health disparities way. Gilda's Club does a great job, but just in terms of how people experience cancer differently, or what their comfort level is, maybe they need to have a specific group that's going to talk in a certain way with a certain population involved, and we want to support those types of things. The facilitation and recruitment versus being part of an audience. We get a chance to talk about things. We make opportunities to talk about different issues within the cancer continuum, but we want them to be there in terms of speaking with us on certain topics. We want them to share of what it is that gives reasoning or gives justification to the collaboration that's happening, along with being part of the audience. And then proposals and grant applications. Those are things that we get email reminders about if you're, in close proximity to and stuff like that. But are we taking these opportunities out to the community to hear from them in terms of writing those things up and being able to walk with saying, hey, does this seem feasible? We always get to that part of, okay, what is the expected impact of how many people we're reaching? And so when we do that with communities, we can feel better about saying, hey, we are going to recruit 50 people, right? And if we have the community with us there saying that, we are informed that, we have extra support in being able to do that recruitment versus just being able to go out and expect people to be signed up to participate in research as subjects, right? If we're doing it in the best ways possible, they'll be doing both. They might help give good verbiage or grounding to the application proposal, along with saying, hey, I have 3 people that I want to get signed up for this particular project or opportunity. Next slide, please. Now we're here to the thank yous. I want to thank the community partners first and foremost that allow this work to be successful. I want to definitely thank the Carbone Cancer Center and the Wisconsin Cancer Collaborative, and also want to give an acknowledgement to colleagues from the past that I've worked with in the CHDI and my present team that it exists right now. Just work with a great group of people and really believe in everything that we can continue to do as we carry forward this banner. As you see, I put my email address down below on this slide if you would like to reach out to me afterwards with any questions or potential opportunities where we can connect and collaborate. I would definitely appreciate that. So how are we doing with time? We have some things, questions and chats. Here we are.
Great, Joshua. Thank you so much. And I appreciate you just rolling with it today. So we are good. And that was absolutely amazing. So Joshua, thank you so much. And I do want to open it up. I know you were excited for the dialogue and to see if there were questions or comments from the group. So I am going to stop sharing so we can kind of see each other as a group and see if there were any questions in the chat. I see there's one from Paula. I don't know if you were able to see it, Joshua, but have you experienced trust issues as you reach out to a group of people that is different than you represent? And if you did experience this, how did you overcome that kind of lack of trust or trust issues?
I've been pretty fortunate. I think at this moment, I haven't gotten necessarily a mistrust vibe or a situation that has come up. Now what happens is with the way things move institutionally versus in the community, the timelines are different. Sometimes the community is a lot more fluid and able to be nimble and agile in what they're trying to do, and maybe we can't necessarily match them. And so within working on specific things, there might be like timeline things that come up. And so I'm trying to be diplomatic in this answer. So I guess an example might be when how a research project comes about and like people leave their positions and things like that. And so things might slow down for us and we don't have answers. And it's not that we don't want to give people what they want, but it's just, these kinds of things, maybe something is embargoed. um, those things can potentially be sticky points or cause mistrust. And what's needed is continued touch, continued outreach, or making sure the acknowledgement is there until things can come back around to be satisfied in terms of maybe that exchange of information. And so being able to say, hey, this is where we're at with something, we're not quite ready to present or give the information that we thought we would have. And so being as upfront as possible and saying, hey, we want to continue to work and push this forward, and this is what we can do. So being able to really be as open and honest. But I guess in that situation, how much are we able to consistently do that touching, that connecting with whomever, that's going to show them, hey, it's not that we don't have value in what it is that you're doing or want to respond. It's just that we are at a standstill right now, and we don't want to um, uh, give you something that's not quality. And we can go back to that level of rigor that I was talking about, coming from a cancer center, coming from the expectations of National Cancer Institute. We want to continue to use those things. And so maybe framing it in that way, being able to frame is a huge part. But also I think that the touches, the ways that we're walking forward with the organization is going to help them understand that we are genuine in where we're coming from. But it needs to be something that the community side can be assured of or affirmed in, understanding that we are not going to just drop off or disappear in this relationship aspect.
Great, thank you, Joshua. Other questions or thoughts or comments?
Joshua, I just want to say that I really appreciate the perspectives you have. I do a lot of community outreach and engagement down here in Milwaukee. And I think your point about sort of meeting people where they are and the pivot that Carbone did in terms of addressing COVID was really impressive. And I think that just sort of shows not only the trust you have outside Carbone, but within Carbone to get the support you needed to be able to do that. So amazing work.
Thank you. That's really, I do appreciate hearing that. And yeah, the across group, building of relationship and stuff like that. The thing that I can point to is it's going to take time. We kind of hear about it. We may write about it, but when it comes down to it, it may work the other way around. Maybe the institution has a very tight timeline. Some of these cycles are working on a year's timeline. If we don't have a relationship already in place and we're expecting to do work within a year's time, that could potentially not be something that a community organization can accommodate. And so being too forceful in this situation may cause distrust, or the community member is going to feel that they're going to be like, okay, so what's the rush around this, right? And so being as clear as possible when it comes to what your needs are as an internal or inside an institution is going to really help them be able to say, hey, this isn't something that we want to pursue at this time, or we don't necessarily have the ability to walk with you in doing this type of project or activity programming, what have you, right? And so the communication is going to be key. The timing is going to be key. And really just is there somebody that may be able to have a relationship where you can coordinate a sit down, right? Or a virtual sit down at this point to really talk through some things and have a good understanding, because assessment and evaluation happens in communities all the time. It may look different, but it's happening, and they're going to give the yay or the nay based on how those interactions happen. And you want to just be as upfront as possible and be clear about what it is that you say that you want. And then on your side, you want to be able to document and share those kind of follow-up steps with whomever you're connecting with.
Well, Joshua, thank you so much for your time today. And something really fun about Joshua and I, we connected that we went to the same middle school. So as he presented on his Meadow Ridge library, I said, that's fantastic. That was my library. I walked home from school every day. And he said, me too. So it's kind of fun, even as the Wisconsin Cancer Collaborative and the planning, the connections you can make. So I will say this, Joshua is an amazing resource. He is an absolutely fantastic individual to work with. So please reach out. I know he's sincere in his saying, here's my email address. And as you heard from him today, just wonderful information. So thank you so much, Joshua.
Thank you,
and I
Ben,
will
for having me.
turn it over to Dr. Stolle.
Okay, great. Again, thank you, Joshua. And now it is my pleasure to introduce our next speaker, Kirsten Norsling. Kirsten has been with Gilda's Club for in Madison since 2008, and she wears multiple hats. It looks like she oversees the support groups, leads education and other programs that provide cancer patients, survivors, and their families with a community when they're going through their cancer journey, resource connections, and independent of their clinic experience, which is really important. And I think we all know how impactful Gilda's Club has been, not only in Madison, but nationally. Gilda's is available to everyone in the state. The one thing that I've been so impressed about is their capacity to ramp programming up and make it available to more. And so this is one of those sort of blessings in disguise from COVID. And they're available to everyone in the state, regardless of insurance status, cancer type, or other limiting factors. And it's really their goal that no one faces cancer alone. So I'm super excited to hear about the incredible development and evolutions that they really, you know, I'm missing the word here, but all the great energy they use to make this more broadly available. So Kirsten, take it away.
Thank you so much. And I'm just realizing that I think I mixed up my letters and my thing. I was an LPC, not a PLC. Anyhow, thank you very much. These things happen. Thank you for this opportunity to talk a little bit about how we in the last year and a half have learned to pivot, adjust, and find new ways to do our work. I think Josh talked a little bit about the challenges of working within a large organization and how slowly things can move and change and shift. And I think one of the things that, just to right off the bat, one of the things that's true about Gilda's Madison is we're a small crew, and that makes us able to be quite nimble and change things as they go. So next slide, please. Actually, you can skip that one and go to the next. Thank you. So back when we were, when the pandemic was just in this little tiny pandemic problem, it was just this virus somewhere doing something bad to a lot of people, we're kind of looking at it and going, okay, so how are we going to make this shift? And we really recognized the challenges that we were going to face very quickly, and also recognized how important that community was that we had at the clubhouse primarily, but also in some of our rural communities where we did have some support groups. So, our big questions were things like, how can we as a cancer support community, the community and the club, right? How are we going to continue to offer critical support to people dealing with cancer, whether they're currently in treatment, managing an ongoing long-term chronic cancer, supporting someone, or dealing with their lives after a diagnosis or after treatment's over? People still depend on us and the community and each other to give them that support and that space where they can share the things that they can't share, and learn the things that, as was talked about earlier, there's cancer has a whole new vocabulary attached to it. And for a lot of folks, you know, Gilda's Club is the place that they go when their worst nightmare has become reality. But we're there, and we're there to make it a little less nightmarish. So what do? We moved our program as much as possible. Thank you. And so that we moved our program online. And so let me talk a little bit about what our program is. At its core, it was our in-person stuff, right? It was the yoga, the cooking classes, the support groups, the hanging out, the cooking classes that I would do in the community room between yoga or after yoga. So people would come downstairs after yoga, they're all sweaty, they're kind of hungry, they get a snack. We make lunch all together using some new healthy recipes, and then they would eat. It was great. It was community. It was space shared. But we need to figure out how to move all of that as much as possible. And also our workshops and our lectures and our education pieces. Next slide, please. The Kids Support Program. Well, it has been a part of the community since the very beginning. Kids connect with other kids who are also living with cancer in their lives. Most of them have a family member. This community of children and families lessen their isolation and fear and the stigma of talking about cancer. We tried hard to make this work virtually, particularly right off the bat, just to okay, we'll just shift it. But kids just didn't have the bandwidth anymore. They were so exhausted because of school. And I'll discuss a little bit later about how we've reimagined that. And our kids program is back on. It just looks different these days. Next slide, please. Our survivorship programming post-treatment life is a different and sometimes challenging navigation space to be in. So what we do is we provide a special support group for people who have completed treatment. It's called Moving Forward, and it's helping them just sort of navigate the emotional challenges, but also the mixed messages and the conflicting things that we hear about, things like food and diet and exercise and stress management. But we also, and so we listen to those, and we also look at tips for making things better and helping people to navigate that time. Next slide, please. We have an amazing patient advocate. She helps our members with things like insurance and Medicare and second opinion. Sometimes she's been dealing a lot lately with appeals. Insurance companies can be a challenge sometimes, and helps people figure out disability stuff and ADA accommodations, and helping people to think about and navigate some of the clinical trial pieces. It's like, hey, I'm looking for this, and where can they go to participate in those? And provides tons of information and referrals to local, regional, national resources to anybody dealing with any cancer diagnosis. Next slide. Our treatment decision plan process is a guided discussion, and we call it Open to Options. It's a guided discussion that really sits down with the patient and sometimes their partners or a support person, and looks at helping them think about what their questions are for the physician as they are preparing for an important appointment, or looking at helping them think about what their treatment options are and coming up with the questions to ask their docs. It has been actually reported when we've been doing satisfaction surveys with folks about it, is that, and the feedback, just random feedback, hey, Kirsten, it was really great to have done that open to options meeting. I walked into my doctor's office actually able to ask the questions that I wasn't able to ask before. I was too scared and didn't have them well processed in my head. So it's just amazing. Next slide, please. We also been adding our distress screening. This screening is brief for people with a diagnosis. The screening literally is 15 questions, and it has been validated to do an assessment for anxiety and depression, but also help guide the resources that we need to provide for the members. We also have a version of it that is for caregivers, and it is in English and in Spanish. Next slide, please. Our educational resources are plenty. They have been nationally, they've been winning tons of awards, and really look at a wide variety of topics, from caregiving to clinical trials, to talking to your kids, to information about specific cancers. It's a really great resource that resources are in English and in Spanish. And so if people are looking for resources, go to that site and you can find them. It's cancersupportcommunities.org/publications. Next slide, please. Super excited. 3 years ago, in 2018, I should say 4 years ago, we added My Lifeline to our list of, our stable of resources. And My Lifeline is this great resource that is sort of like Caring Bridge or Care Pages. But in addition to keeping your friends and family up to date with what's going on, you also have the opportunity to ask them and schedule them for help. So one of the challenges that that I think we all have is asking for help, right? And when you have this schedule, you can actually ask for very specifically, these are the things I need, whether it's food delivery or taking your kids somewhere to just get them out of the house because you need 2 hours without a lot of people around you, or whatever it is, rides, anything. It's you put the need out and your network can schedule themselves. It's so much easier than saying, hey, Beth, can you help me with that? And Beth can't help me with that because she's busy, or it's just not in her wheelhouse for that particular thing. But she'd rather do this. That would be more in line with her. I actually know somebody who got her apartment painted using My Helpline. Next, please. The last thing we do is our Cancer Experience Registry and Research. It's one of a kind registry that really looks at the lived experience of patients and caregivers. And it's been really important to have that and to be able to utilize that research information. Next, please. Okay, so what we know, and I know that a lot of this is going to be covered later. The next few slides are sort of overlays and of what's coming up later today. But 34% of cancer patients are at risk for depression. This is what we know. 43% of patients and 50% of caregivers are at risk for anxiety. Cancer is an apple cart upset, to say the least, and it can be hard to manage. And the other thing is that not only does depression and anxiety impact how we show up to things, but it also impacts how expensive treatment is. Next slide. So just a little piece here, sort of COVID in a snapshot. COVID was at the heart of everything, and it changed everything in 2020. There was a decrease in diagnoses, and there was a major screening decrease. So I think we're gonna, down the road, it's gonna impact us in ways that we don't know, and I'm not really looking forward to that, but I also recognize that this is what we got. Next slide, please. So just a few headlines from the last year. Fighting cancer in a pandemic means fighting cancer alone. Support groups had to be, were in-person support groups were canceled, but for us, at least, and the people at Gilda's Club and people in Wisconsin, they at least had access to the virtual groups that we had. Next, please. So along with that apple cart of cancer, there's also the apple cart that goes along with COVID. 67% of people had disruptions in their care or delays in care. Everybody was just worried about what was going on. 47% discussed the risk of cancer. And now it's becoming, just anecdotally hearing from our members, particularly on the heels of Colin Powell's passing, it's raised a lot of anxiety about the overlap between COVID and cancer. Next, please. Right, and we can skip this one. Thank you. All right, so we had some work to do when we realized that what we offered was, something that was unique, and there were holes in the support systems that were huge, and there are limits to what people can do, and limits. Is my audio going? I'm getting some weird feedback here. Is it okay?
It's okay. It's a little echoey,
Okay.
but it's okay. If your mic's all adjusted, we'll just keep.
All right, let me know if it gets weird. Sorry. So the challenges, were major, and where we were at was we had some planning to do, and we had to do it really quickly. And the planning started on March 11th, and we went live with Zoom calls on March 16th. So it was a fast and furious week at Gilda's Club. We had to inform people. We had to make plans. Next, please. We had to get our technology set up, train our staff. We have a staff of about 10 mental health professionals that we work with, and they all needed to have appropriate technology and resources. We needed to get the word out to our members about what was happening, so that we didn't feel like, hey, I showed up and the doors were locked. Some of our members don't have internet, they don't have emails, and they really depended on us sending those calendars out to them every 2 months. And so we actually had to do a lot of letter writing and inform people, just saying, this is what's going to be happening, and these are ways that we can help. Even if you don't have internet, you can still call into classes and support groups. We needed to breathe. I think the whole world needed to remember, like, okay, on top of all the anxiety we have going on, we have to and things we have to do, we have to breathe on a regular basis. And then we needed to make the right choices. And that was a lot of us trying to figure out exactly where we were going to go. So, some things made the cut, most things made the cut, some things did not. Next, please. And we got Zoom just in time. Our national office had actually been working with working on the Zoom contract to do some more virtual work, but many of us weren't we were not hot on the technology. We believed that, and I still believe in the power of being together. But I also believe in keeping people safe. So next, please. So we went through the process of getting information to members. I had to have some conversations with our instructors about what this was going to look like. And they were such troopers. They hopped right on, and it was great because one of our instructors, who usually is out of the state for several months, was able to actually tap into classes and do classes, from Arizona. We established new group norms and guidelines about how to use Zoom. Our classes got really creative. We did some pickups, and then just being able to get all the information and the technology to staff so that they could do their groups was really important. Next, please. This is one of the examples of, I just wanted to share this because it's so great, an example of one of our workshops just last March. Next, please. And then we found new ways to connect to the community. We are a small, as I said earlier, we're a small program, so we were able to make shift quickly, and the support with the support of our national office, it was really great. But also to partner with some community organizations here in town. We partnered with Goodman Community Center to put together our art show and art contest that we will actually be doing again next year. It's a fabulous opportunity to highlight the skills and the talents of our members. And then we were able to still continue to take on interns. We just got really, really creative, and between Edgewood and the UW, we've just been working creatively and collaboratively to make that happen, which helps us and it helps the students as well. Next, please. These are a couple examples of our summer art intern project. Next, please. And some of the food from our cooking classes. I have to tell you that our cooking classes have taken a major step up. The bar on that has definitely been raised. We had just been starting to have a conversation with a chef to do a specific workshop with us, and when the pandemic hit, he said, I'd be happy to do this on a regular basis. And so we have these amazing cooking classes on a regular basis. Next, please. All right, so what had to shift? Our kids programming has now shifted from its traditional hour and a half, which is a long time for kids, to a 45-minute program or 45-minute group where they play games and talk about things and do some health boosting activities and mental health boosting activities. Our education program, we partner a lot with a lot of doctors and health professionals to come and do speaking opportunities. When furloughs were going on, that kind of became it became more difficult. So we're still doing them. We're getting back to them, and I'm really excited about the partnerships that we have been having with the speakers that we are able to bring in. And our new member orientation, which used to be an in-person group activity, is now an individual activity, and we've shifted how people come on to or enter into the Gilda's Club scene and community. Next, please. So who showed up? About 20% of the folks were under 40. about 26% were middle-aged. And then about 55 were over 56. So 55% were over 56. So an older, as is typical, as we're dealing with cancer. But next, please. Most were women, but I do want to just make a real strong reminder. The Gilda's Club is for anyone with a cancer diagnosis. Next, please. 64% of the folks that came were actually people with a cancer diagnosis, and 30% were supporters. Next, please. And then, although 37% of the folks were folks that were dealing with either themselves or their support person, their person that they were supporting, were breast cancer diagnosis. The rest was that full spectrum of a cancer diagnosis. So we really, we meet all cancer needs. Next, please. So the impact of the virtual programming that we've had is that this is from a member. She says that having these available indefinitely allows people to participate who don't feel well enough to travel and who can't fit the trips into their schedule. It's also given us more access to really interesting classes, social events, and lectures, and we can do these throughout the country. And we've actually partnered with one of our affiliate partners in LA for an activity, and they're hopeful that we will be continuing virtual for at least in some ways for the future. Next, please. So what were people attending? A lot of support groups and a lot of healthy living, healthy lifestyle classes. I love the fact that people really were finding that timeline of, now is a really hard time, and I do need to make sure that I'm taking care of myself. So whether it's our weekly groups or monthly groups or those yoga classes, has been really important. Next, please. Next, please. So our website has been the greatest thing for us to be able to get a hold of people and to get the word out. We do send out a weekly email to all of our registered members, and I think actually some of you who have contacted me that I've got onto some lists might even be getting those on Wednesdays. Next, please. And people are coming from all over the place. We actually have people coming from as far away as Wausau and Green Bay. One support group has folks from Platteville and Milwaukee, as well as the Madison area, which is really exciting. Next, please. Our classes, we do evaluations on most of our workshops, and this is just one of a snapshot of the feedback that we got. And I love the way that they're like, we want more, we want more. So next, please. And clearly they're happy with how things are going. Next, please. This is we keep putting the pieces together, and like this mosaic, which is actually a photo from a workshop that we did last week. The pieces don't always fit perfectly, and we are hoping that they continue to do what they need to do. Next, please. We've had some challenges. My paper is out of order. We've had some challenges. The challenges include technology. That's a major one. It's a major one. The think they call it a technology gap. The digital divide, that's it. I'm just losing my words. The digital divide is real, and it's real in Wisconsin. There are areas of this state that just don't have the areas that don't have broadband, and then there are individuals who don't have access to the internet, and that I think is something that I would love to see fixed. But that's a bigger picture than what I can do. So bigger conversation. And then our scheduling is also an issue. You know, just looking at what works for people when everybody was working from home and when we were on lockdown, we could do a lot more things during the day. Now that people are going back to work, they want evening programs again. And yeah. So it makes things interesting for staff. Next, please. Next, please. Benefits. We've had so many huge benefits coming from this. Things of people not having travel time, so we are able to get people from across the state. We have people coming from Platteville, Green Bay, Wausau, Milwaukee. I think there's somebody coming from Superior, all over the state. And again, everything the Gilda's Club does is free. And so because of its freeness and because of its because of our shift in not being able, or our fluidity about coverage, it doesn't matter where you're getting your treatment. It doesn't matter who your insurance company is. It doesn't even matter if you're choosing to get treatment. And that's a little controversial, but some people choose not to, and that's okay. It's not okay, but they make the choice, and they can still get access to professionally facilitated mental health and mental wellness groups. Location is no longer an issue. Some people like the fact that you can be not in physical proximity with folks. You can come to group even if you're not feeling well. We've had people literally come to group from bed, which is amazing. And it's very intimate, and it's such a trusting, open thing that it's just really great. And then people connecting who have those less common connectors, whether it's young adults or people with less common cancers. And then again, with the partnerships with our colleagues across the country. Next, please. One of those partnerships is a game night that we're doing. Next, please. So some of our concerns or opportunities, continuing to set clear guidelines, being flexible with how people engage with us and where they engage with us from. Remembering to send tons and tons and tons of reminders to people and email check-ins and phone calls. We've had to do a lot more high touch and than we had in the past. And the other opportunities is that we put things on YouTube. The Gilda's Club has a YouTube channel. We have some lectures and workshops there, including a 15-minute Tai Chi practice, which is fabulous, and some of our lectures. Next, please. Next, please. Where to next? So we are currently going to be virtual until at least January. After that, we'll see, but we are anticipating telehealth being a part of our world for a while. So on we go. And this has given us an opportunity to really reimagine how we do things and where we want to be and reach out to the rest of the state. Next, please. So life is about not knowing, not having to not knowing, having to change, taking the moment and making the best of it without knowing what's going to happen next. Delicious ambiguity. And I will leave you with that delicious ambiguity quote from our namesake, Gilda Radner. Next, please. Sometimes the paths we lead take us a lot of places. Questions, and next, please. And next, please. All right, questions. Thank you so much for this opportunity.
Well, thank you, Kirsten. I really appreciate the information, and you already have comments in the chat box. So one is just what a wonderful resource this is. And thank you for sharing. And a question specifically about connections to La Crosse and the La Crosse healthcare, but I suppose maybe statewide. Curious if you are looking to make more connections statewide now as you look to be in a little bit of a more virtual space.
We're always looking to make more connections. Yeah, as I said earlier, Gilda's Club sort of picks up where the amazing prevention and education pieces sort of leave off, and we're the place that people find when the cancer is real in their lives. So, and we're available to anybody across the state.
Great, thank you. On that, there was a question about the My Lifeline service and if that was available beyond the Madison area.
You bet. It's virtual, and so anyone, it's cancer support, like mylifeline.org is the service, and it's really great.
Wonderful. And Mark, from your team, it looks like just put a list of the upcoming virtual cooking classes over the next few months. And that picture alone made me so hungry. So I think that's probably a popular class, I hope.
They are very popular classes, and our chef Michael, is just amazing.
Other questions or thoughts? We do have lots of comments in here. Very informative, wonderful presentation. I think you have a resource that maybe not everybody knew about, but once you learn more, you figure out just what a fantastic organization and absolutely wonderful resource for patients and their families.
Oh, thank you.
Other questions? Okay. With that, I'll turn it over to Dr. Stolle.
Great. Thank you so much, Kirsten. It was so good to hear, that Gilda's Club was so available. And in fact, people were able to access and did access. And that's so exciting to know. We're going to take a break to introduce my friend, Kim Kinner, who's the Senior Director for Cancer Control Strategic Partnerships with the American Cancer Society. Kim actually started her career in cancer patient and family support services, and since then really has spent most of her career advocating for and working with vulnerable populations. She's a caregiver herself, and I know that about her, so you always have to be careful not to take advantage of that, because she's willing to help anyone at any time. And at the heart of it, she's really just a person, as I just said, who wants to help others. So with that, I'm going to introduce Kim, and Kim, take it away.
Great. Thanks so much, Dr. Stolle. I really, really appreciate it.
You're on mute, Kim.
I am? I'm on mute?
No, you're all set. Sorry, I think Dr. Stolle might be having some issues on her end with hearing. I can hear you fine.
Yeah.
Okay.
You're good, Kim.
Okay, I'm good. Okay, Dr. Stolle, apparently you can't hear me, but I think everyone else can.
Okay, sorry.
That's okay. It's all good. Thank you so much for that introduction. If you want to go to the next slide. Thank you. And Kirsten, thank you so much for your presentation. That was really fantastic. And you mentioned some things around cancer screening. And so I'm just going to take a little deeper dive into that and sort of the impact that COVID has had on cancer screening. So next slide. So as the pandemic really branched out across the world, we saw shifts in healthcare demand and delivery and care. And we saw an unprecedented drop in breast, colorectal, and cervical cancer screenings and diagnostics. And so here you see decreases between 83 and 90% compared to 3-year averages. We know a backlog of cancer screening exists, and health systems have really been challenged to adopt new processes and protocols that were necessary to safely restart cancer screening. Next slide. And so how has the reduction in cancer screening during the pandemic affected early detection of cancers? And this slide is actually from our article in JAMA Network 2020, which shows us how there has been a significant decrease in what we would normally see in terms of diagnosed cancers. The green dotted line for each cancer site is the weekly average diagnosis prior to the pandemic. And then the bar graphs depict the decreases in diagnosis for each cancer. So for example, we've seen a 49% decrease in colorectal cancer diagnoses, and in breast cancer, a 52% decrease. Next slide. The COVID pandemic is expected really to result in increased cancer mortality over the long term due to delayed diagnoses, and Kirsten had alluded to this as well. Interruptions or alterations in potentially curative treatment, the possibility that some adults will abandon maybe their previous patterns of preventative care, which would include cancer screenings, and the expectation that millions of adults will remain unemployed and without health insurance. So this graph really shows the National Cancer Institute estimated a 1% increase in deaths from breast and colorectal cancer over the next 10 years, the equivalent of approximately 10,000 excess deaths due to the pandemic's impact on screening and treatment. So next slide. In addition to decrease in cancer screenings and the decrease in cancer diagnoses, we have seen the pandemic significantly impact certain populations in other ways. The graph on the left is data from the COVID tracking project, and it depicts the impact of COVID on certain populations, and in particular shows that Black, Hispanic, Native American, and Asian communities have had an unequal burden in COVID deaths compared to white populations. And then the graph on the right shows further impact on those populations with the decrease in employee-sponsored health insurance enrollments. And we know that a lack of healthcare access leads to poor health outcomes. Next slide. People with COVID-19 who are Black, Hispanic, or American Indian, Alaskan Native are about 5 times more likely to be hospitalized than those who are non-Hispanic white. And that's what this graph is depicting. So all of this data really taken together, the low screening rates, the lower cancer diagnoses, high impact of COVID, and a decrease in healthcare access, points to the reason why the American Cancer Society and really all of us, have an urgent need to focus on getting people screened. Next slide. And so this slide shows the overall cancer incident and mortality for all cancers in Wisconsin. Next slide. And this slide depicts the cancer screening rates prior to the pandemic. And you can see that prior to the pandemic, our breast cancer screening rates weren't great. And when you layer that on top of the effects of the pandemic, we really have certainly work to do. Next slide. So getting people screened isn't going to be easy. You know, it's going to take a long, sustained approach. Systems and social challenges will really need to be addressed. I mean, we've seen now that the pandemic has exposed longstanding racial, economic, and access to care inequities. On top of that, there's been, you know, patient fear, reluctance and confusion with the health system. Our primary care capacity has really been challenged. And the loss of employer-sponsored health insurance, as I mentioned before, is an impact. And our health systems have been challenged with putting into place new processes and protocols. Next slide. So an issue really of the size and complexity needs a multifaceted approach. And that's what the American Cancer Society has been trying to do, and sort of what we created. We like to kind of refer to this as building blocks. And really on the left is the work that we're doing on more of a national wide scale, and the work on the right is the work that we're doing on more of a regional and local basis. So we're leading a national consortium on screening with other national organizations such as the CDC and the American College of Surgeons, and others, and that kicked off in March. We've also introduced a Get Screened public awareness campaign. We have research that's focused further at the impact of COVID on cancer. And then we're working with our state and local coalitions and partners, such as all of you, and on the Wisconsin Cancer Collaborative. We continue to work with our health systems to implement screening interventions. And then our advocacy arm, ACS CAN, is really focused on influencing policy that affects screening and access to care, such as Medicaid expansion. So some of this work these are things that we've been doing, that's been happening, but we're certainly adding to it. So next slide, please. So earlier this year, we announced our partnership with the CDC on our screening initiative. In addition, we rolled out a toolkit and guidance for health systems to safely and equitably resume cancer screening. And then the National Football League funds the Change grants with the American Cancer Society in every NFL market. And through this critical partnership, health systems have reached over 1 million individuals. This has been a partnership of over 10 years. And through this partnership, we've been able to provide patient education and screening resources, reminders, and navigation. And so in Wisconsin, we've traditionally always had at least one of the NFL Change grants, since we do have the Green Bay Packers. Since I sit in Green Bay, I had to throw that in. This summer, we announced a partnership with the Commission on Cancer and the National Comprehensive Cancer Network on increasing cancer screenings throughout health systems. And you're going to hear an example of that shortly. So next slide. So I've given you really a lot of information, and I guess I would say if you walk away with, sort of one takeaway today, please know that there are resources to help you increase cancer screenings. You probably don't need to create anything yourself. It's already been created, ready for you to use. And so on the screen here, just, a few of the resources that I pulled forward. We launched the Get Screened campaign this summer, and there are links on our website with both an English landing page and a Spanish landing page. We also have specific tools for comprehensive cancer control programs and coalitions, and that's you, that's all of us. So I encourage you to tap into that. We have a great interactive cancer statistics website that you can pull state data from at any time. And then of course, I have to put in a plug for the Wisconsin Cancer Collaborative. And on the website, there's a whole cancer screening and COVID-19 toolkit. So that's, you know, kind of a lot of resources that you can tap into. And so speaking of some great resources, I am actually going to turn this over to two fantastic physicians to talk about their new multidisciplinary high-risk breast clinic. So if you'd like to move it to the next slide. It's my pleasure to introduce Dr. Cynthia Chow. She's a breast surgical oncologist at Aurora Baycare Medical Center in Green Bay. She specializes in treating benign and malignant breast diseases, as well as offering preventative care for those at high risk of developing breast cancer. She was born and raised in Anchorage, Alaska, where both of her parents were doctors when Alaska was still a territory. She attended college at Stanford and went to medical school at NYC Columbia. Realizing her mistake not being a city gal, she then went back to California for residency at UC Davis in Sacramento. She's been doing mostly breast for 10 years, including 15 years in Seattle, Washington. Dr. Chow has been in Green Bay for a year, keeping things on track for Dr. Lumen's arrival. And so Dr. Natalie Lumen is also a breast surgical oncologist at Aurora Baycare Medical Center in Green Bay. She specializes in treating benign and malignant breast diseases, as well as offering preventative care for those at high risk of developing breast cancer. Dr. Lumen was born and raised in Marquette, Michigan, so she's a Youper, and attended undergrad at Cornell in Ithaca, New York, which has a similar feel to Upper Michigan. Then went on to medical school at Wayne State in Detroit and general surgery residency at Beaumont Hospital in Royal Oak, Michigan, which is just outside of Detroit. Following residency, she went on to breast surgery fellowship at Northwestern in Chicago, and like Dr. Chow, is now happy to be out of the city and up north again. So welcome to you both, and I will turn this over to Dr. Chow.
Great, thank you so much, Kim. And thank you everybody for having us here. I can't see my picture, so I don't know if we are centered. Let's see.
You are good. We can see both of you.
Great. Thank you. So this section is breast cancer screening and prevention, and we're going to talk a little bit about our program here that we just initiated. Next slide, please. As Kim said, we are coming out of a tough time. It's still going to be a tough time for the next several years too. Associated with this time has been a feeling of helplessness. A lot of women skipped their mammogram last year, and so this year in 2021 are thinking, I don't know if I really want to come in and have it. What I missed a year, I'm afraid that I'll find a cancer. So what we're trying to do is kind of shift that focus. Instead of saying, oh, let's go see if I have a cancer, we're trying to say, come in and check your risk. Let's see what your risk is, and we can teach you how to lower it. We can teach you what that risk number means. And we want to focus on outreach to these patients and empowering them. Next slide, please. So our outreach is kind of based on identifying patients at the time of their visit. So the first step is at their appointment, either for their mammogram or primary care visit, we get the information that we need to calculate their risk. There are multiple ways to calculate that. We'll get into that. Eventually, we're hoping that our electronic medical record will do that. We're planning to. We're just not there yet, so things are fairly time consuming. Once we have those calculations, we identify people who are at high and moderate risk and invite those people to the appropriate high-risk clinic. And once they're there, or even if they just choose not to come in, we are stressing, educating them about their risk. Some people think they're at high risk and they really are not. Some people think they're not at very high risk and they're at significantly high risk. So we want them to know what their risk is and then also give them some options on how to lower that risk. Next slide. So we started our pilot before the EMR is implemented with the calculator. So we're manually calculating, and it's been quite time consuming, but quite rewarding. It's our pilot, so everybody kind of stepped up to the plate. Mammotechs are doing the questionnaire, getting the information we need. Initially, our breast radiologist, Dr. Masty, did the screening of all those questionnaires and even some calculations. We've taken that over now due to the volume. Our clinic staff do the data entry into the calculator. And then once we have the risks all set, the nurses step in and the navigator stratify. The high-risk patients get invited to a clinic. Even our genetic counselors are stepping in and helping to screen charts, because patients who are going to need to see multiple providers, those are the ones we're targeting to bring into our multidisciplinary clinic, and others who really may not have such high risk and would benefit from seeing us still, but not necessarily multiple people. They're invited to our other clinic where they don't have to see multiple people. Next slide. So calculating the risk is very time consuming at this point. I just want to mention some places, Illinois and Iron Mountain, already incorporate the risk calculation into their EMR or their mammogram reports. To me, it's been unclear how this number has been used, because we don't get a lot of referrals from, say, primary care doctors saying that this patient's number is high, we'd like you to educate her. What we do see is some patients that will see that on their report, not understand what it means and self-refer. But other than that, we really don't see how this number is used. So we are focusing on using that risk as an outreach tool to bring patients in, to let them know what their risk actually is. One thing we have discovered is there are so many questionnaires. We screened like 1,000 women in our first 6 weeks that we really do need to prioritize the calculating and the inviting of patients in. So currently we're only doing people that have a family history of breast cancer, but eventually we'll be doing everybody. Eventually including those with ovarian cancer risk, pancreatic cancer history in the family, and then when the EMR is incorporated, when the calculator is incorporated into the EMR, everybody. Next slide. So Dr. Luhman's going to go over this in more detail, but basically there's an average risk, which I do want to point out, that's a lifetime risk of 12%. That's our average. We really can't get much lower than that. Then there's moderate risk and high risk. Next slide. So here's just some quick views of what the calculation looks like. Next slide. This right in the middle bottom of the slide, it says powered by CRA Health. That is actually the company that we're using now through the Mastery of Breast Surgery, and also will be contracting with us to do it through our EMR. But you can see in that first bolded line, there are 5 different ways to calculate risk, and they're all over the board from 9% to 25%. So clearly there are multiple different ways to do it. This patient using her Tyrer-Cuzick version 8 is at 25%. My patient's name is Minnie Mouse. Dr. Luhman has a different patient name. And then you can see down at the right lower corner, the breast density by mammogram, how that impacts their score. So their lifetime risk does go up as the breast density goes up. Next slide. A couple things that I wanted to stress. The risk changes over time. So initially you might think, well, lifetime risk, that risk shouldn't change over my lifetime, right? Not true. So it actually can change every single year. But in that particular year, that's your risk for the rest of your life. And the things that can change this calculation every year, the first arrow, your weight and the breast density on your mammogram. And then the second arrow at the bottom, the red arrow, if you have a biopsy, and those results can dramatically change your results. So this is really just to show some of the things that go into how your risk can change. But just because someone is not high risk at say age 52 does not mean that she's going to be average risk at age 65. So that's why it's important to have a calculator that's convenient and can do it frequently. And so doing it in the electronic medical record, I think, is a wonderful way to speed things up and make it really easy for providers to see what their patients' risks are. Next slide. This is Minnie Mouse's family history, not very exciting. Next slide. And then this is a closer look at those models. The top red arrow there is her 25%. So anybody over 20% is considered high risk. And then the second red arrow, I just wanted to call attention to that because that is not something that we see currently, that I see currently in other EMRs that have it incorporated into their record. The Gale 5-year or the Tyrer-Cuzick 10-year risk is something that really can bring home to the patient that they are at risk of getting breast cancer more than the average population, which is say 1 to 1.5% within the next 5 to 10 years. And we use this to help guide chemo prevention. Dr. Luman will talk about that more, but it is something that we are planning to incorporate into our calculations and our program. And it's not something that's been seen, that I see routinely in other systems. Next slide. So after we identify high-risk people, these are the clinics that they can be invited to. We have the luxury of having 2 of them here. The multidisciplinary clinic, where they see at least the first 2, breast surgery and medical oncology, and then genetics if appropriate. And then I do want to stress the medical weight loss referral. We've just started that. And it's huge because so often we tell patients, you know, your risk is going to be lower if you can lose weight. And then, you know, see you later. But here we have the luxury of having a weight loss clinic we can refer them to, and they work with nutritionists, and Dr. Luman will go over that more. But being able to tell the patient, we know that it's hard, we know this will lower your risk, and give them an option has been really, really helpful for us. The second option for our high-risk clinic is just our breast center. They see one provider, and that one provider kind of reviews everything, but then if patients are interested in those other things, they get referrals out to those separate sections. So the advantage of that one is patients sometimes are very concerned about how many copays they're going to rack up if they come in. So if that's their primary concern, we'll invite them to our regular high-risk clinic and then refer them out, and they'll have the option of seeing patients at that point. Next slide. Right now, our multidisciplinary appointments are fairly limited. So we're focusing on the higher risk people, greater than 25%. Not average high risk, the high risk people from 20 to 25 come to our breast center. Eventually, we're hoping to have many more multidisciplinary appointments, but that's been wonderful for getting patients in the door during the pandemic, because they come and they sit in one room and we all go into that room. They don't wander around the hospital from oncology over to genetics and then on to the surgery clinic. They sit there and we go to them. So they like that. And then the moderate risk people, we do want to empower them and educate them also. So we send them a letter and it tells them what their risk is. It educates them on ways to lower their risk. And then they have the option of calling to make an appointment and come discuss that in person if interested. Next slide. So again, this is our kind of one of our goals. The moderate risk patients get that letter and we offer them an appointment. We are actually seeing several patients come in because they are curious what it means and how, and they want to come and talk about the lifestyle choices they can make to lower their risk. And then our high risk patients are offered an appointment, and more details are to come with Dr. Luman. Next slide. So last couple things: how to start your own program, decide how you want your program to look. The one provider, that is the most common because many community hospitals or more rural hospitals do not have the luxury of medical oncology coming in to do a multidisciplinary clinic. But if you do have that option, if you do have MedOnc, the multidisciplinary clinic is something that patients do appreciate. The advantages, again, minimizes their trips in and their number of appointments because we pre-screen and they don't see genetics if they don't need to see genetics. Another advantage that we're finding is that multiple providers emphasizing the lifestyle changes has been great because they hear it from the surgical provider and then they hear it a slightly different way, but emphasized also by the medical oncology provider, and they realize there really is something to this exercise and weight loss. And the best thing is they leave with an action plan. They make their decision about their MRI. They know if they're going to get their blood drawn to have their genetics tested. They know if they're going to do their chemo. So they leave with a plan, and then we take their information and contact them and get all their studies and their next appointments set up. Next slide. So the risk calculation, of course, the EMR calculator is most efficient. Not everybody has that luxury. Manual calculations, there are multiple options and we're happy to discuss. I am a locums and leaving the program, so I'm volunteering Dr. Lumen and her staff to discuss any options about calculations. We know the pros and cons, we've tried a lot of them. And then a final thing is have your referral network set if you're going to have just the one provider so that that person knows who to refer to. And again, Dr. Lumen will be talking about that more in her portion. So next slide. And here she is, specifics of our program.
Perfect. Thank you, Dr. Chow. So as Dr. Chow mentioned, I am new to BayCare. I'm the new breast surgeon here. And so I'm coming in after the high risk program has been established. And so I've been very impressed with, what they've started so far. And we've made a little bit of changes going forward. So I'm going to talk more about the nuts and bolts of our program to just kind of give other places or other sites some more information about how you could set up a similar program at your site as well. So I believe if we could get my slides, please. Thank you. So I'll be talking more about Aurora BayCare Medical Center's specific multidisciplinary high-risk program. Next slide, please. So we start with our patient pool. Right now, we are doing all patients that come into Aurora BayCare for their annual screening mammogram. So with that population, we catch women that are older than 40. As Dr. Chow mentioned, right now, we're only screening patients with a family history of breast cancer, just because that's sort of what we have the bandwidth for at this time. And then soon with the Epic EMR integration, once those risk calculations are automatically entered into the patient chart, we will screen all patients that are coming in for their screening mammogram. We're also going to be rolling this program out to outlying mammography centers, specifically West Mason. So kind of modeling our program there once it's also Epic integrated into Epic. We have patients that come in for self-referrals that have heard about our program in the community and think, gee, I have a lot of family members with breast cancer, and kind of call in to see if they can be seen. And then also once this is integrated into Epic, we expect to have more PCP referrals. So as it's automatically calculated in the patient chart, they go in for their annual exam with their primary care doctor, and that doctor can notice, hey, they're at elevated risk for breast cancer, or for whatever reason, get them in to see us. And this will be significantly expanding our patient population as well, because we'll be able to catch women that are younger than screening age, so women in their 30s or maybe younger, and also, any males that may have a strong family history. Next slide, please. So we start with the introduction. When patients come in with their screening mammogram, we're going to be handing out a flyer, just kind of introducing the program to the patients. We've got feedback from the patients that, the more information they can get about what's happening, what's going on, the better. Some were, kind of surprised the first time they get a letter in the mail and cause a lot of anxiety. So we're starting to introduce the program right at the time of screening mammogram, say, we're going to be running your risk and you may get a letter in the mail. And this is sort of what the program is about. Next slide. And so sort of to highlight what Dr. Chow had gone through, but basically the patients are completing a high-risk questionnaire at the time of that screening mammogram. You can see they're asked questions about their family history, their BMI is calculated, their breast density, hormonal history, and then previous biopsies. Next slide. And then all of that information gets entered into our risk calculator. So right now we are using the American Society of Breast Surgeons Mastery of Breast Surgery Risk Calculator, which is uses the Cancer Risk Assessment Health program. And so this is the printout that gets reported once that information is entered into the risk calculator. It's kind of similar to what Dr. Chow showed, but this is exactly what we use to counsel the patient during their high-risk clinic visit, and also the copy of the information that we give the patient. So you can see there's the risk of a BRCA1 or BRCA2 mutation, and then the risk of breast cancer. And it runs multiple models and gives us the 5-year and lifetime risk. Next slide, please. So based on those risk results, we categorize patients into different thresholds. And so we use the Gale model and the Tyrer-Cuzick model. We categorize patients into either a moderate risk, a high risk, or a very high risk. And you can see in the green boxes at the bottom that we've sort of, within our department, used national guideline cutoffs to help guide what we're going to determine as patients that are moderate, high, or very high risk. And then that helps determine how we're going to invite those patients and what setting we're going to see them in. So the moderate risk patients, we have categorized as patients with a Gale 5-year risk of greater than 1.7, but less than 3%. And that helps guide us about our recommendations for risk reducing medications, and or patients with a TC risk of 15 and 19%. And those patients at moderate risk get an invitation to be seen in our breast clinic by either an MD or an APP. Our high-risk patients are categorized as patients with a Gale risk greater than 3% and or a TC risk greater than 20%. Those high-risk patients get a slightly differently worded letter that is kind of more strongly suggested they come in and see us, again, an MD or an APP visit. And then the very high-risk patients are any patients with a TC lifetime risk of greater than 25%. These patients get an invitation to be seen directly in our multidisciplinary high-risk clinic. So not just the breast clinic, but the clinic where we have multiple providers available at the same time. They also get a follow-up phone call about a week after their letter goes out, just to kind of follow up, answer any questions we can, and then really suggest that they come in and see us. Next slide, please. So at the breast clinic visit, that's the visit where they're coming in to see just the single provider. We sort of discuss all of the different interventions that can be done for patients at higher risk for breast cancer. So we discuss supplemental screening with MRI if they qualify. We discuss risk reducing medications. If the patient's interested, we then refer to medical oncology. Some places the breast clinic or the provider is prescribing those on their own. But the way that we've set it up here is that we're going to have a medical oncology APP handling those referrals. We also talk about lifestyle interventions. We talk about maintaining a healthy weight, diet, and exercise. And I'll talk about our medical weight loss program in a couple slides. We talk about limiting alcohol and also smoking cessation. At that visit, we also assess for appropriateness for a genetics referral. And if the patient is interested, then we give that referral. Next slide, please. So the multidisciplinary high-risk clinic is that clinic for those patients with a Tyrer-Cuzick lifetime risk of greater than 25%. And so we really want those patients to come in and have the full experience and see multiple providers if they're interested. So the participants in that day, which right now we're holding once a week, sort of based on all the participant schedules, are the breast surgeons, the medical oncologists, and the genetics team. So we kind of break down our roles accordingly. The surgeons discuss supplemental MRI screening and order those if necessary. We talk about lifestyle interventions, diet and exercise, and the medical weight loss referral. Medical oncology talks about the risk reducing medications with the patients. And then if they do qualify for genetics, genetics will see them and do their first pre-test counseling visit. And then if they're interested, they'll order the testing rate that in there, and often patients go straight to the lab and get their blood drawn. Next slide, please. So for MRI screening, I was just going to highlight the portions that the surgeons talk about because that's sort of our baby and what we cover in these visits. The NCCN recommends annual supplemental breast MRI screening for patients with a greater than 20% lifetime risk. I've listed some other factors in the bullet points, but really, since we're using this risk screening tool, I'm kind of focusing on the lifetime risk and how we interpret that to help guide our recommendations to the patient. So our practice has been generally, if the patient has a greater than 20% lifetime risk, we always give them, allow for patient-led decision-making, give them the pros and cons of an MRI and, explain what the process will be like. Some patients choose to do that maybe every other year. With the patients with the lifetime risk greater than 25%, obviously they're still making their own informed decision, but we kind of more strongly encourage that they get that annual MRI. Next slide, please. The medical weight loss clinic, like Dr. Chow mentioned, has been, I think, a huge benefit to our program. It's run through sort of the bariatric program, but anyone that's coming through our system can be referred to it. The inclusion criteria for referring patients includes patients with a BMI greater than 27 with a comorbidity, or a BMI greater than 30 without a comorbidity. So this really gives a patient, a chance to kind of own their weight loss, and also some support though, because like Dr. Chow mentioned, we just tell them you need to maintain a healthy weight and then go on your way. And I think a lot of people have been trying to do that, but they've been trying to exercise without finding great success. So this sort of gives them a little bit more structure and a little bit more support in the process. So this program starts with a nutrition consult. Their BMI is calculated. Goals are established for that specific patient, and they're educated. They're also given a specific diet plan. Then they follow with an APP after that diet is established. And if they don't achieve a weight loss of greater than 10% in a certain amount of time, then they get kind of escalated and they may have a visit with the physician to discuss medication. Beyond that, if they're still having difficulty and they've been in the program for a while, they can consider bariatric surgery. And then the program also gives other referrals such as physical therapy, behavioral therapy, sleep medicine, endocrinology, and GI. Next slide, please. We definitely do a lot of smoking cessation in our clinic, in the breast clinic and the high risk clinic. We start with, cessation counseling. We assess the patient's interest in quitting. And then beyond that, we give referrals kind of appropriate to the patient's level of interest. So sometimes we provide medication on our own to help support their quitting, but we also refer to our Aurora Baycare smoking cessation program and also support groups that we have. Next slide, please. So our outcomes. The program started kind of mid-June, and then as of about a month ago, we've seen 23 total patients. Like I mentioned, we're able to see patients 1 day a week, 3 days out of, or 3 weeks out of the month, just based on our schedules and availability. Genetics has met with 16 patients, or had genetics, 16 patients were referred to genetics, and 15 were able to see them at their visit. For MRI, we have 14 patients that have had or scheduled one. One is considering an MRI. We have found 2 abnormalities thus far on MRI, and actually one was a cancer, and that patient was a self-referral to our program. We have 19 of those patients that are planning to follow up in the clinic. So despite what interventions they choose to follow with MRI or medications, we also offer to follow them in clinic for their annual exam and their mammogram. 18 patients were offered risk-reducing medications, 4 have started it, and others are considering. We have 6 referrals placed to medical weight loss, and 2 patients declined. Next slide, please. So I wanted to go over sort of lessons learned as we've started rolling out our program to help others that might be interested in setting up a similar program. First and foremost, it's important to establish your network and your resources first. So depending on where you are, you need to make sure that you have genetics available, or if not, how you're going to refer to that. Medical weight loss clinic, like we mentioned, is a great addition. So if you can refer to a similar program in your community, and also make sure you have the capability to do breast MRIs. You need to decide if you're going to have physician and or APPs lead the visits. So far here, we sort of started with all physicians, and the APPs more shadowing, with the eventual plan to turn over to the APPs once we are more established. It's also a good idea to kind of establish your resources in terms of your literature and your letters that you're going to be sending out to patients. So the informational letter that they get at the time of the mammogram, the different invitation letters and how those are going to be worded, and also any supplemental educational material that you're going to hand out at your visits. Administrator buy-in is very important, so you can establish these resources and have the ability to roll the program out. Establishing team roles also from the beginning is a good idea. Who's going to talk about what types of interventions? So like I mentioned, surgeons here do MRI and lifestyle. Who's going to take over prescribing risk-reducing medication? Is that going to be med-onc, or is that going to be surgery as well? And then we recommend starting with inviting your highest risk patients first, and then increasing the patient pool so you don't really exceed your resources. We could offer, once we're rolling this out to all the patients with screening mammograms, it could easily get out of hand. So we want to be able to make sure we can service those highest risk patients first. We recommend scheduling the high risk visit as close as possible to the time of invitation. We find that this helps with patient education and retention, and also, with patients keeping their appointment rather than, booking 2 months out and then maybe forgetting that they had that appointment scheduled. And then lastly, organizing the high risk day efficiently, figuring out which providers are going to see which patients and in which order so that the day is most efficient for the patient and also for the provider's schedule. And next slide, please. So that's it. That's all we have for now. If anyone has any questions or comments, we'd be happy to take them.
Great, thank you so much. Thank you, Dr. Chow, Dr. Lumen, Kim. Appreciate all the amazing information. This pandemic has impacted us so much, and we know, as we've said, cancer didn't stop. And very, very interesting information, Kim, and a solution, right? There we go, Dr. Chow and Dr. Lumen. So we appreciate it. Questions from anybody? We have one in the chat, is a question from Dr. LeConte, is what is the ongoing role for telemedicine in cancer prevention?
I'll go first. I think that there is definitely a role for telemedicine. I think it'd be a good place to start and getting the patients in the system, discussing their options and what kind of interventions they would be appropriate for. But I also think that they, as a follow-up to that, would need to be seen in the clinic to have that exam by a breast provider.
So we do find a lot of women coming in are saying, once I stop seeing GYN because I'm only getting a pap smear every 3 years, I'm not getting a breast exam because I guess the rules are different in primary care. So some of them are very thankful that they can once again have an annual breast exam. I think that's, I always tell my kids, they ask about telehealth, and until we can learn to do breast exams through telehealth, I still need to see patients in person.
Thank you. Another one for Dr. Chow and Dr. Lumen. If a woman has already had her breast screening, can they still see you for a high risk assessment?
Absolutely. I mean, just because they've had, we can use that information from their mammogram, know that they're up to date, and then we can take their specific history and hormonal history and run that risk calculator for them. So it doesn't necessarily have to be done at the time of screening mammogram. We just find that that's a good entry point for us to get patients.
And we do have some patients that say, I just had my breast exam by my PCP, 2 weeks ago. So then our discussion is mostly, counseling about lifestyle and options for risk reducing and early detection for them.
Mm-hmm.
I have to say, as a clinical psychologist who spent my entire career focused on lifestyle change and worked in the genetic risk clinic, when BRCA1 first came out at Rush, I am so impressed by the linkage to support for lifestyle, because it is such an important aspect of care, and has, as you said, go exercise, go lose weight, and patients just feel oftentimes shamed or sort of hopeless and like, oh, okay, you go get some exercise. So I really think that aspect of care is really important. Do you also address, and I may have missed this, I apologize, I got a call I had to take in the middle of this, alcohol intake, since that's such a huge risk factor?
We address it and we talk about, the risk for increased risk for breast cancer and limiting alcohol intake, 3 to 4 drinks per week. But I think that's definitely a good point where we could offer more support for people that are heavier drinkers. I mean, we just kind of say, you should limit your alcohol intake, but I think that, providing other resources in that setting would be a good idea too.
Show them what 5 ounces of wine is. I'm always like, no, not that glass that holds a bottle of wine is not 1 glass. So.
On there, what do we have in place to reach non-majority populations? That is an excellent question. We do have the Oneida tribe here and the Menominee tribe. And a couple years ago, before COVID, we were actively reaching out and starting to do education programs with the tribes. And that just kind of got shut down last year completely with COVID. So it is on our agenda. First, we're going to start kind of our support groups just through, Facebook. And then eventually, as things open up, we are hoping to get back out to reach out to them. I don't think that we do. I think they get their mammograms elsewhere. So we aren't going to be able to actually get them in through our current program. So reaching out to them, going to their community is going to be very helpful.
And this is Dr. Walker. Is that also true for the Hmong population? Because it's fairly large in that area. Am I correct?
Yes. The Hmong population, I've seen a few come through just from the screening, but it's hard to reach them. I think eventually it will take reaching out to their community center and seeing if we can organize something, because I don't see a lot of them.
There's another question. Are high-risk clinics associated procedures covered by most insurance providers? Yes. So the consults with medical oncology and the surgery provider are. Genetics is a wonky system here, where if they're seen with oncology, the fee for that is rolled into the genetics billing. But in terms of coverage, yes, they are covered, but there is a copay for each specialty that they see at multidisciplinary. And then for MRI coverage, each insurance provider is different. I think once they hit the benchmarks of greater than 20% or maybe increased breast density, more insurance providers are likely to cover that. But the way that we do it here is, if they are interested in MRI, then we have them schedule it, and then prior authorization is done before the actual test. And then that information about how much the copay or the cost is going to be to the patient is given to them before they get the MRI, so they can determine if they want to go forward with that.
Wonderful. Thank you so much, Dr. Chow, Dr. Lumen, Kim Kenner, absolutely fantastic. Thank you for sharing all of this information and just being an amazing resource here in Wisconsin. So I will turn it back over to you, Dr. Stolle.
That highlights the work of the Wisconsin Well Woman program. So timely given our presentation on screening and seeing that huge reduction in breast cancer screening, especially. The Well Woman program provides breast and cervical cancer screening services to low-income, uninsured, or underinsured women in Wisconsin. And this program is a part of the CDC's National Breast and Cervical Cancer Screening Program, which just celebrated its 30th anniversary with an inspirational virtual event. And as part of that 30th anniversary event, Wisconsin was chosen to be featured because of the dedicated and passionate partners that certainly work every day to save lives in our state. So congratulations to the Wisconsin Well Women Program Director, Gail Johnson, and also congratulations to all of the Well Women coordinators and everyone who works with that program across the state to facilitate screening. So now we're going to start the video, and then we'll have a quick touch point afterwards.
Milwaukee has a great need for breast cancer screenings. One of the things that women that we serve struggle with is health literacy.
I think they understand the need to have healthcare, but I think one of the problems is that they have so many other things going on in their lives that the last thing that's on a person's mind when they have those kind of situations is healthcare.
It's important for the state health department, for the Well Women program, to work with individuals who are already engaged, who have established trust, who can help bridge that alliance and ensure that it is implemented, in a fashion that's convenient, not only for the agency, but more importantly for the community as well.
Every Saturday, we have at least 3 to 4 programs going where we're in the community, somewhere, at a church, we're at an apartment complex. We go to homeless shelters, we go to the homeless clinics, we go to drug rehab centers, trying to encourage as many women as we possibly can how important it is to go ahead and have the screening done.
It just takes a moment, in some instances, to stop and just to listen.
The driving factor behind creating this establishment was making sure that Native Americans always had a place to go where they would feel like they were getting their medical services with dignity, because they weren't always getting that in the regular medical system.
We don't trust the healthcare system because no one has really made the time to help us understand it. And so that's where we feel that the Milwaukee Consortium for Hmong Health is playing a very, very important role.
My role is being a bridge. I'm able to work with my Karenni community because I'm from there. I know culture. She's saying that I cannot speak the language and I don't know how to make the appointment on my own, so I was going to call you to help me with that.
Many of us have been touched by different types of historical trauma that has affected the way that we have, formed our medical opinions. Hopefully, Pink Shawl's work will help kind of break that cycle.
When we were educated that regular screening so that the doctors can catch it early and help us, it can save a lot of our lives. It makes perfect sense for us to pursue this, to bring more education to the community.
I just can't thank this program enough. It gives me a sense of satisfaction knowing that I'm saving lives one mammogram at a time.
If we are committed to serve the community and honestly respond to those needs that we can easily address, we can affect a mighty change.
Wow. That's just amazing. Gail, are you on?
Yes, I am, Dr.
Will you come
Stolly.
off camera for a minute, please, or come on camera?
My camera is not working. That's why you can't see it. Unfortunately, I'm in the health department with my mask on and my camera's not working, but I am here. And let me say to all of you, first of all, we were shocked when CDC, when the producers contacted us about coming to Wisconsin. There were 6 states that were chosen. Wisconsin was one. And like I always say, first of all, our coordinating agencies are the backbone of the program. We've got great providers. I've used the term altruistic to describe our providers with CDC. We have program partners and, the patient navigators. So while we are not a perfect program, we think we are a very good program. And we always, strive to get even better. So thank you all. And, we're just going to move forward. And we had a wonderful 30th anniversary celebration with CDC. And again, we were just amazed to be chosen to be one of the 6 states featured. And let me say one more thing. This is the video for Wisconsin, but throughout the actual 2-day 30th anniversary meeting and celebration, CDC and their producers, they had different little pieces of video featuring Wisconsin at different times. So just wanted you to know that. And I had no idea, again, exactly what it was going to be, but I think we are all pleased. And again, I thank everyone here for their support.
And we thank you and your team for your incredible leadership and championing of screening. Wow, just amazing. Truly awesome. Thank you. Okay. So thank you everybody for coming today to the first day of our 2021 Cancer Summit. We hope you learned something today, made a connection with someone you didn't know, had a little idea put in your brain that you can carry forth. And to further stimulate our brains, our hearts, our souls, we have day 2 tomorrow beginning at 8:30, runs until 2. If you have not registered yet, please do so. You don't want to miss it. And also, if you're not a current member of the Wisconsin Cancer Collaborative, sign up, okay? And also encourage others to sign up who are not. We can all do more together. Also, last but not least, feedback is important, right? We only get better with feedback. And so we ask that you complete the evaluation form, which we sent to you electronically. And that's it. Thank you again for coming, and we'll see you bright and early in the morning. Have a great day.
Thank you, everybody.
Thank you.